Welcome back to the RPE podcast and part two of our bone stress injury podcast with Blake Withers. We hope you enjoy.
Connor, I know that you were asking questions on why is a stress fracture so much harder, or the rehab process? Why does it look like different to just getting back from a regular
Fractures.
fracture? What's the kind of difference, like a regular compact kind of fracture or a whatever, like some other type of failure fracture? Or do you have any thoughts on that, Blake?
On the difference between a fracture, like a stress fracture and a stress reaction?
No, stress fracture, and then like say I have just
Broken your
I've
thumb.
broken, yeah, I did break my thumb, but that was a bit. But like say someone does a Weber like a good fibula fracture, and then they they're got their plates and everything back in and gone, and once that kind of is healed up, like that 6 weeks process, and you're back to kind of going pretty quick. Whereas BSIs can be a little bit more harder than that. Do you think it is just the pure fact that when you have an actual big fracture, it's that forced rest, whereas sometimes some of the BSI have pushed themselves and would continue to try to push themselves because it's not like a fully failed fracture?
Yeah, it's a really good question. I guess you're right with the people that are going to sustain a stress fracture, and we talk about runners all the time because it is most likely to be a runner. I feel as though the other type of population that get these stress reactions are people that have quite a lot of systemic comorbidities, and they're really predisposed to getting these stress reactions. But I think you're right where the the motivation to get back to running and activity and movement, which was the thing that caused it in the first place, is so high, and they're just trying to find some other outlet where they're probably not really letting things recover, or the reason that they got the stress reaction in the first place was something else that they haven't addressed either. Whereas a fracture, it's usually like acute, you roll your ankle, you get tackled funny, and it's not really something that was going on in the background. Whereas a stress reaction, there's kind of some other things that are like, oh, you might just have your bone remodeling just might be poorer because you've got something else going on, and that's always been the case. But that's a really good question. What do you guys think?
I've heard before that because like a stress injury obviously happens longer over time, that you
Mm.
essentially accrue like lots more micro trauma. And if you're accruing lots more micro trauma that's not getting a chance to recover, then your body actually has to like, in terms of its remodeling, the osteoclasts are going to have to eat more of that first before they can, well, not before, but like at the same time that they're trying to build it back
Mm.
up. If you've got that happening diffusely through like more of a bone than potentially you would just with like a clean break, then it potentially requires more energy and more time to get like just like a greater amount of bone to be
Mm.
replaced.
Yeah, it's like
Does
change the porosity kind of thing, like throughout a higher surface area, like the bone micro architecture to change because it's more diffuse.
Yeah.
Yeah, that's
Yeah.
really
Is
interesting.
have you kind of
And
heard that
then
before
probably
or?
I'm in that direction, Connor. And then also the one I'd add on top of that is probably like the acuteness of so you had something that was
Mm,
previously healthy, right? And then it's just been acutely
yeah.
damaged. And so you, as Blake said as well, like both those added together in my head is kind of what happens, where you have something that was kind of previously healthy, and basically you just have a big acute kind of trauma to it, and then it's got all that really good blood flow and everything into it. It's usually not in an area that has, well, you said navicular actually has probably better blood flow than we thought, but it probably is, in an
It's still
area where
less.
it
Yeah,
is.
yeah, yeah.
Yeah, and it's just things are probably more susceptible or more systemically set up to be like, hey, this isn't just a complete failure of the stress recovery adaptation cycle for so long that you've thrown yourself into heaps of debt. You actually are doing really well, and your system is primed and ready to heal, maybe compared to a
Mm.
system that wasn't primed and ready. Well, it's proven it wasn't primed and ready to be healing.
Yeah. I don't know if you guys find this with some bone stress injuries, but the people that do sustain them, I mean, there's always the smaller percentage of people that are just really motivated and just love their sport, and they don't understand the seriousness of the bone stress injury, where they've got a femoral neck or an navicular, and they're like, oh yeah, I'll just wear the boot around, I'm just going to start running, I don't have any pain anymore, I'm just going to start. And I wonder if sometimes that has to play into it, where like, oh yeah, it's just a stress reaction, it's not really broken, it's just like a stress injury. Whereas with a fracture, like, oh yeah, I've actually fractured the bone. And I think oh, I'm just trying to think now. Man, I need to get better at remembering this. You guys might know it. Have you seen that the study where I think it was done over in the UK, where they told people they're like, you have a crack in the bone versus you've broken your bone. Can you remember that
Yeah.
study? Did you know what?
Yeah.
Yeah. Can you repeat it?
So essentially, it was the same. They've just done it in low back pain on like the words we use as well. Like if we use things like non-specific low back pain versus you've injured a disc or something like that, the way that you explain it to people changes how they will behave, like to help. So it makes sense. Like the one with the fracture, and this is crazy in Scotland. Like if you ask someone, "Have you broken any bones?" They'll say, "No, but I fractured my leg." So that comes up for me like daily. I'm like, okay, so now I've had to change my questioning to be like, okay, broken any bones, or have you got any fractures? So I think the way that they looked at it in the study, I think they used the word crack. I think they used the word like a line, or I think, and there was just like really, I can't remember, but they used really subtle differences in the like the term that they used to help describe how someone's break was, and it changed completely like their kind of beliefs around how they would approach. That's the one you're talking about?
Yeah. And I wonder if that happens with bone stress. Like if you're in a consult with me and I'm explaining it to someone, like I'd really go over the top. Like, this is a really serious injury, and I sound like a broken record. And I tell people that I'm like, I'm going to repeat myself a lot. Your bone density or your bone strength wasn't able to handle the load, and unfortunately for a long period of time after, it's going to be at a reduced amount than what it was before. So you need to promise me that you're going to do some good osteogenic exercises and really control your load, because the big thing, which we didn't mention before, so there's a 6 and 7-fold increase, depending if you're male or female, of having a bone stress injury again if you've had one previously. And we know the incidence within 6 months is so high, and surely it has to be in part because people don't ever return to the bone resiliency they had previous to the injury. Like, it has to be somewhere in there, or the factors we didn't address properly have just come together again to cause another one. And you hear so many people, like our elite, two of our elite Australian women marathon runners have both had proximal bone stress injuries, and so have our males. So it's hard.
Yeah, I've heard as well on that point. With the like, obviously if people have gotten into that environment where their bone's not happy, it's not accepting the amount of loads, it's not recovering how it should, that the underlying processes, say they're like hormonal, say they're like energy depletion, say like whatever it may be, those actual processes take way longer to return to normal than what, say, like normal bone healing would. So the reason that the stress fracture happened, or the like significant stress response, takes longer to recover than, say, a normal fracture would be, like you said, the environment, the milieu of hormones, all that kind of stuff is like still so not back to baseline, or like still out of homeostasis, so that one, the new bone that they do put down potentially isn't as healthy, or it doesn't recover at the same rate as someone in an otherwise healthy like state would be in.
Yeah. And they've done those studies on like when they divide females into 3 groups of, I always forget the names, but like amenorrhea, so you don't have a regular menstrual cycle. There's one that starts with E, where you've had like between 6 to 9 menstrual cycles in the last 12 months. So it's somewhat regular. And then people that have a normal, healthy menstrual cycle. And they've looked at, who is more likely to sustain a bone stress injury, and it's the people that have amenorrhea. Who's more likely to have another one? Again, it's the people that are with amenorrhea. And then also they looked at their bone mineral density and found that even from a recovery point of view after the injury, it's still less than what the other people were, purely just looking at that factor. And of course, there's other variables, but that systemic health just plays such a significant role. And like I know people personally who have struggled with amenorrhea, and it's taken them 2 years to get back a regular menstrual cycle. So those hormonal things just take such a long time to get back into to how they were, or what we would consider, healthy.
Mm-hmm. And yeah, we'll talk about this, in another episode where we just talk about fracture healing. But when you look at the things that do kind of in a normal fracture, not stress fracture, the things that kind of limit the ability to heal, it's obviously blood supply and things like that. But then it's like the systemic effects of like obesity, smoking, like menopause, like a lot of hormone driven things that will like cause just a normal fracture to not heal. So if these people are already in that state and then they have that fracture, it's gonna take longer. Just like any other fracture, like a normal fracture, if we dub it normal fracture, would take longer to heal in that environment. So yeah, in saying
That's
that,
actually,
like,
that's got me wanting to ask you there, Blake, one thing. We've talked a lot like runners, sporting, but have you seen diagnosed bone stress injuries in just like someone who you would definitely not have expected it kind of coming in on your intake form to go, oh yeah, this was even on my radar. Like your prior credence, your prior probabilities were kind of low.
Yeah, that's the other category of bone stress injury that I see of people where they have not genetic, they have a systemic comorbidities happening that significantly reduce their bone mineral density, and it's unfortunate, but it seems to be most likely in the female above the age of 45. So there's obviously some comorbidities potentially happening. There's some age-related changes happening. There's also very likely, some systemic health hormonal things happening as well. And some people like base of fifth, cuboid, navicular, where they've either seen the orthopedic surgeon. So they've seen the GP, seen the orthopedic surgeon, who was then sent to us after they've spent their time offloaded in a boot. And then they've come to see us for more of the offloading, which is typically, if it's indicated, it's typically, shoes that are relatively stiff and rocketed, sometimes foot orthoses or heel lifts or wedges to just try and take some pressure off the bone. But the base of fifth ones we see a lot of, and they've just been wedged laterally. So we just put a big wedge on the outside to take some pressure away from that metatarsal. But yeah, that's the other category that I would see the most commonly, and they're the two that I would separate them in.
Cool. So
Awesome.
kind of based off that, moving towards like the treatment side of things, obviously when someone experiences a fracture or a bone stress injury, one of the major things we want to return them to is like a normal bone density. And we know the effects that like deloading has on like losing bone mineral density. So how do you kind of balance that? Obviously you want the site that's fractured or the site that's gone under a major stress response. How do you kind of make sure that's healing, but then also make sure that the rest of the bone, the rest of like in that local bone, and then the rest of the kind of other bones don't diminish to leave them at kind of like an increased risk in the future?
Yeah, that's a really good question. And this is the thing that I harp on the most about on social media. Like I'm sure I've lost followers because I just keep repeating myself that when someone has a bone stress injury and you have clearly diagnosed it, you've got a treatment plan in place of how long you're going to offload them for, they understand how long they're going to be offloaded for, and you've gotten to that point, then it is your job to have them understand that they are going to have some deconditioning. And that's just inevitable because we have to be quite aggressive with the offloading, whether it be boot and crutches or just a boot, or they're coming out of the boot and they just have, they're just doing ADLs as a bare minimum. So they need to understand that if we can reduce as much deconditioning as possible, they are going to start so much closer to where they want to be right at the end when they get permission to start to load again. So wherever it is locally, I am doing everything that I possibly can elsewhere. So if they've got a metatarsal or a tibial bone stress injury, they are doing everything that they would usually do on the contralateral side, as much as still doing their hamstrings and their quads. So I'll get them doing, things like wall sits, abductor slides, hamstring slides, trying to maybe do some single leg squats, and jumping and hopping definitely on the other side. And I know if you guys are aware of the study where they've had to offload people on one leg, and they've done strength and conditioning on the other side, and they've found it's like an 8% crossover or something. So it's obviously some neuromotor or neuromuscular transfer. So people are doing that all the time. Very rarely, depending on if there's some systemic things, I won't get them doing too much cross training, because if they don't have much energy available, and this is really common in triathletes and in runners as well, they're like, great, I can't run 7 hours. I'm just going to go and swim for 9 hours, and it's less impact, and they just end up using more energy, and they have an impact on their bone remodeling, which I've been caught out before. I remember this person doing 14 hours of swimming when they did 6 hours of running, and I was like, that is crazy. It's just unbelievable. So I'll try to get them doing some form of cross training, making sure it's not loading the bone. Like if they've got a below knee bone stress injury, making sure they're in the pool, they're using a pool buoy and they're not kicking, and making sure they're not pushing off the wall. Like the really basic stuff. They can go on the bike and that. But yeah, it's that deconditioning you have to prevent, and they're going to be so much better off when they start the loading process, because they're not going to have issues on that side. I've had 2 times in my last 12 months where someone developed patellofemoral pain on the same leg as a bone stress injury, and a hamstring tendinopathy, one younger person, one older person. And I have to believe, like, they had no history of it. I've got to believe it was in part because of the deconditioning. And although we did some stuff for that, potentially returned too quickly. So that was a learning for me. So I'm trying to get them to do that as much as they can, and it's somewhat of an outlet for them. But yeah, they're doing everything they can. And then once they're out of the, once they're out of the boot, or even while they're still in the boot, and we're in that kind of 4 to 6 week or 4 to 7 week, I'll get them out of the boot doing some short foot and some below ankle foot intrinsic stuff. Like I'm getting them to pick up stuff, doing some big toe stuff, doing some short foot to just try and keep some stiffness or some strength in their foot. And they can just do that relatively non-weight bearing. It of course loads the bone, but for those low risk areas like, metatarsals and some of the tarsal bones, it's going to be fine.
Cool. Great. So in terms of, go on.
I was going to say, interestingly, and we could, and that I'm enabling the takeoff of APRA responsibility hats here, and say that discharge all medico-legal responsibilities to any hypothetical we're into at this stage. So when I broke my own thumb, day 2, I was like, I wonder what would happen if I just can figure out what the SRA, what its level capacity is here, and just load it
below it,
little bits, and often like a bone loading principle thing, but I braced it, but I'd come out of brace through tiny, it was super interesting. That's the short foot exercises, because obviously you are, as you said, you're putting
stress.
We know that the muscle kind of contracting is bending the bone, and that's kind of stressing the bone, right? And we know that for stress recovery adaptation, it's not just rest isn't the thing that gets it better, right? It's just basically you had a bone stress injury because you didn't match the stress recovery adaptation cycle of your particular bone's capacity at that time. And so again, when it has a stress injury or any fracture, it still has a stress recovery adaptation cycle, right? Rest, which is our medico-legal advice, is definitely there, but it's probably lower than what it can actually tolerate. It'd be interesting to know, ideally over time, what you could do. You might be able to come off and do the tiniest little, you can do flexor hallucis longus,
on day 1.
Yeah. That's what it'd be so interesting, but we're definitely not advocating for.
Do you think that we're too conservative, Steve?
No, I don't. I think we're good. I just think that biologically, there's there's a lot more plausibility in there being actually some sort of load that something can handle rather than rest.
Yeah. I agree on that. There's a cool study called the lone bone of the Achilles, and I've got it pinned on the top of my Instagram, where it looks at the modeling of all the Achilles plantar flexor loads that you can start from level 1 all the way up to level 10, which might be doing a lunge versus sprinting at 12 meters per second. 9 meters per second. I think that might be like the world record, but somewhere
That's pretty
really
quick,
quick.
yeah.
Somewhere really quick.
V fast.
12 is super quick, but nine's doable.
Yeah,
Anything
and
over
they were
7 sprinting.
I'm probably around round 4. They looked at running and walking as well at maybe that was at like 2 meters. So they looked at low level running and walking, and like doing a double leg calf raise is significantly less load on your Achilles, which inherently means your plantar flexors, which inherently means your bones, than walking. So if you're going to tell someone, hey, you can come out of the boot and start walking now, well, it's like, well, shouldn't before that they start to do some double leg calf raises, because it is less load than walking. So I think we can really bring people forward a little bit more, and obviously being safe and being transparent with what we're doing. But if we know the loads are less, we can be pretty confident that it's going to be okay. And as you guys would know, like with these lower risk ones, we're loading to a point of relatively no discomfort. If they have a pain flare up, you haven't refractured it. Usually we just say, take 3 days off and then do the activity that made it sore and just see how it goes. We might need to regress a little bit, but if you're getting to do some double leg calf raises at week 5 or some flexor stuff and they have a little bit of discomfort, that's okay. You can just say, if you have any pain, we're just going to give it another week or give it another 5 days and kind of go from there.
That's awesome. I'll definitely link that paper because that's super useful.
Yeah, it's good.
I think, is there one for anterior knee as well? I think they did one on like the patella tendon as well.
Yeah, I think the patella tendon and patellofemoral
joint.
Yeah.
Like that.
It's so cool. And it's like, basically, if you ever stuck with rehab, just follow this and then stop where they want to get to. It's really, really cool. Like,
and some of it is counterintuitive. Like for memory with the patellofemoral one, something like a front leg, like if you're doing a step up or something, like your front leg will actually experience less load than like if you were like doing a landing from a box or something. Like
crazy.
I can't remember exactly what it is, but some of it's just counterintuitive. So it's like really cool to see those kinds of studies.
There was one other thing that what you were talking about before, Blake, that I just wanted to, like, again, I'd like to like push on things and just see where the nuance comes in with stuff. So with, you know how like we're always told swimming, like, so you said your person went to swimming and obviously crazy amount of swimming, like they still stayed in LEA. They had all the systemic factors and everything, but like we're always told swimming, like, not an osteogenic activity at all. But like with a lot of the new research coming out, like being where it's the bone torque forces that are the muscle torque forces on the bone being, do you think it is like being important to actually be an osteogenic stimulus in relation to, like, you obviously get your peak ground reaction forces doing something as well, but it is that internal moment as well. Is swimming not osteogenic though because of the fact of the joint angles? They're not like the way in which it's doing it. So say at your quadriceps, at your plantar flexors, etc., whatever they're doing there, it's kind of at a joint angle where it's contracting, but it's not, because it's basically in end range of motion. Your knees are in end range of motion, all that stuff. That actually it's the range of motion to create the torque on the bone, which is kind of more important than the actual muscle force itself. So it's actually the kind of the angle at which the muscle force is being created.
Like if it's completely stretched out. So you mean like doing that they have done a study on bone loading with doing like really heavy isometrics, like a calf raise.
That's what I was going to say. Would an isometric calf raise actually do fuck all?
Yeah, and it did. I'll have to link this study. I remember I've read this a very long time ago, because I was really surprised, because we tell people you have to contract the muscle very hard, and obviously when you go into the bottom of dorsiflexion, that's when you have the highest amount of Achilles load. But they've done heavy isometrics, and it's like the contraction is enough to obviously strain the bone and
bend the bone.
Yeah.
Cool.
Yeah. Okay. So and that was enough, being up in that full. Yeah. Cool. So well, then why swimming? Why swimming shit?
Like you mentioned before.
I guess you don't have, because you're in maximum plantar flexion, but you don't have any resistance from the plantar side. It's only dorsal.
Yeah. So exactly. Yeah.
But I guess for your shoulders and stuff would be with the resistance.
It'd be like a tiny stimulus as well to like, in comparison to like walking. So like if your bone is like used to doing walking. It's adapted to walking. That relative stimulus surely is pretty small.
100%. Yeah.
Yeah.
And like you said before, with like the bones get bored, like what is it, 40 steps on a run, and like we've kind of lost our bone sensitivity anyway. Like for me, like if I swim
Not
a
if you
lap in the
start
pool,
crab walking after 40.
Give us some variability, baby.
yeah, exactly. Run backwards for a bit, run sideways. Swimming's
Knees over
like
toes.
ultra repetitive.
Yeah, swimming sucks. It's boring for your bone and boring for the people doing it. No, I'm kidding. I know people love that. I don't want to harp on other sports, but it's hard. It's tough to do swimming.
That was actually cool, mate, though, the isometric one, because I was like the medial tibial stress syndrome. Like I was saying that I was going to say that's somewhere where diagnosis kind of, you're just like, well, MTSS, I'm going to start you like, probably heavier ISOs to start, bone stress injury, you might be a little bit different. Whereas actually, cool, nice. So the heavy ISOs was a good bone stim. So you could just go, if you're really just like, oh, I'm unsure and I need to see you a few more times to get my base rate up to kind of keep on rechecking and getting a better idea of where I got, those heavy ISOs is not a bad thing then.
Yeah, the studies by CS Flora, effectiveness of various isometric exercises at improving bone strength in cortical regions prone to distal tibial stress fractures.
Yeah, cool.
Yeah,
cool. Let's put it in the description as well.
Yeah,
yeah,
yeah. Which is
we'll break this
cool.
into many different episodes. We'll break it into part one of Mia in there, just
telling you to shut up.
Yeah, the fingers coming over the mouth, I was cracking up. It's not ideal for podcasting.
Just if we rewind like 10 minutes ago, we were kind of talking about like the patient expectations of, okay, you need to know that this is a serious injury that could have some serious deficits for you. In terms of like the other aspect of patient education, in terms of the prognosis side of things, like giving them like expectations about how long this will take, is there like different gradings of stress fractures or different like progression of a stress fracture that might give you a little bit more kind of information around the prognosis that you can then give to the person?
Yeah, it's really difficult, and this is such a gray area because we don't know how to load bone after someone comes out of that offloading period very, very well. Like we've got a bit of an idea of if it's high risk versus low risk, a little bit of their history comes into it. So you can have a bit of a framework of, is it high or low risk? Is it their first or their second? What sport are they getting into? And I think one, which I'm actually talking about quite a bit in the course tomorrow, is the personality type of the person. Are they someone that's really activity dominant? Are they a coper versus a non-coper? If you say you can go out and start some running, are they going to go and run a half marathon tomorrow because they're really fit? Or they're going to be really scared to run because they don't want to end up like their brother's sister's cousin who had to have their tibia pinned, So there's all these other things that impact it. But yeah, it's really difficult to know how much. I think, pain obviously comes into it, and loading with no pain versus maybe an awareness is okay. But like as an example, with like a high risk tibial BSI, the research would suggest that jogging can be anywhere from 3 to 4 months, and full return to sport can be 6 months. Now that's huge compared to a third metatarsal where they can get back to maybe 20 or 30 minutes of running in kind of 7 to 8 weeks. So there's such a difference there. And I really don't have the answer of, once they come out of the boot or the crutches, we're trying to always err on the side of caution, because as we know, the consequences are so high if we get it wrong and we load them too quickly and they end up with another one, or it doesn't heal properly, or all these other things can happen. So I'm always trying to tell them education. And I've been caught out before where I've told someone we're going to be back a lot earlier than what we have. And it wasn't a nice conversation where you're telling someone, hey, just another couple of weeks or another week, or you didn't go too well with this, we're going to have to give you some more time. It does not go down well with someone that's really tied to their activity. And like running is a good example. Like my identity is somewhat tagged in my running. I really enjoy it. And if someone told me, hey, it's going to be 6 weeks till you get back to the thing you love, and now you're telling me it's 8 weeks, what's going on? Which one is it? Like it can be really hard for people. So expectations are great, and always overshoot, or sometimes even just say we'll try our best, but the seriousness of this injury means it's going to take a little bit more time, and always err on the side of caution. But it's difficult, and I don't know anyone, and if there is anyone, I'd be very interested to talk to. I don't know anyone that really knows exactly how we can do it, because you can't really know. You just don't know the pain. Like you don't know how well the bone's doing. Like if your Achilles tendon is sore, when you do some hopping, I've got a pretty good idea of your current tolerance, where if you can hop without pain with your bone, I don't know, you could go out for a run for a week and start running and it could end up as another stress reaction, whereas we know these things with the other tissues. So that's the one thing that I just don't like very much about bones. It's very tricky to predict, but erring on the side of caution and just managing expectations.
Would you almost with that kind of think of it as like, describe it going, hey, this is the healing, this is the medical kind of side, but then we also have like the general physical preparation side, your GPP, to get you back to doing your task, you know what I mean? And unless your task requires, like, unless you have like a specific, I'm running a marathon in whatever time, well then like, yeah, that going cool, we've got to there, but now it's the return to run process and go, hey, you know, the healing generally takes like this long, but kind of reframing it to be like, you can be healed, but it might not be kind of running, and not put the exact timeline on the running for them, but put the timeline on the healing. And
The healing,
yeah, like that kind of makes sense. And then going, hey, we're going through a GPP phase, and that could take, everyone's a bit different, you know what I mean, with how long you kind of need, what type of training you need. We're kind of in that type of phase, and that way to explain it.
Yeah, and I think like my biggest mistake as a clinician is I really love to yap. Like I think, because I'm talking to you guys as an example, I love this so much. So I'm like, oh yeah, obviously the people that I'm seeing, they want to hear me speak about bone structure injuries for 30 minutes. Of course, that's why they come to see me. So I need to probably cut back a little bit on that and just be really short, like you said, where now I'm just telling people that, you know, I kind of use the quadrant model, and you guys would have seen this with the Achilles, where you can have a sensitive tissue that's strong, you can have a sensitive tissue that's weak, you can have a strong, and breaking it down that way. And what I'm trying to get people to understand is you can have a bone that's not sore, but the capacity of that bone is significantly reduced, and there's not much we can do to make it remodel any quicker. So we just have to be guided by these timeframes. And if they understand that, although it's not painful, it's weak, that's a really good thing, because then they're going to be a little bit more on board with the loading stuff. But I do like that Steve just getting them to understand, because straight away they're always asking, I've got a marathon coming up, I've got this coming up, I've got that coming up, can I start to train, can I start to push it? And we know the risk is so high of it happening again, so you want to be, I always say in my mind, I'm like, if we take an extra week or two, although it sucks because you don't get to do the thing that you love, it's probably really good for your bones.
Have you guys heard that? Like, I think it was on PT Inquest. I don't know if you would have listened to it, Blake, but it was like they were talking about bone stress injuries, and I think Eric Mero was saying that he had this case study of a cross-country athlete who had like a stress fracture in her shin. So they offloaded her in the boot and said, "Yep, okay, you're going to be in this boot for 6 weeks. Let's catch up in 3 weeks to see how you're going." So she came back in 3 weeks later, and the boot was completely mangled, like wrecked. And it turns out that she'd been running her normal amount of load in the cam boot. So then they were like, "No, look, you've got to stop running. Like, we'll give you a new cam boot, and we can't have it happen again, blah, blah, blah." And she had like all sorts of things around like body image and all that kind of stuff going on, why it was important to her. And so it was big psychological kind of interventions from then on. But eventually it got to the point where, so after the second or third time where they tried to put her in the boot, they had to cast her. They literally were just like, "Okay, let's cast you." So the first time they did the cast, they did below knee cast, so she could still run on the cast. So then she went and ran on the cast, and then she ended up with a full leg cast, so she couldn't run.
Wow, so lucky to not do any kind of secondary injury. And I hate to say that, I really don't want to say that that's runners, but like, speak again, I'm just rattling off research because I'm doing this course and it's all fresh in my mind. But there's been plenty of studies looking at the personality types in runners, and higher obsession is one that ranks very, very high with runners. So love the sport, you're obsessed with it, you're going to do what you can. And I've heard of that with the sports doctors, like telling people with the higher risk ones where they've had to do full leg class, they just don't listen, or they're on crutches and they're just like, "Oh, it's all right, I'll just walk through it," and it doesn't go too well.
So yeah, I think that was just to highlight that we can do our best in terms of like educating them around like this is going to heal well and we're just going to do general preparation. But if we don't really address like the underlying goals and reasons that they're doing this stuff, then they're not going to do anything that we say.
They've done a study on, and this is with tibias again, where they looked at someone has a tibial fracture. They looked at using the wearable watch, how many steps they do once they come out of the boot, and the average was 10,000 in the 2 weeks coming out of the boot. So looking at people's loads, definitely with their activity, but also you need to understand of what they're doing, outside of that. Like if you've got someone that's a nurse or a doctor, or they're a tradesman, or they're going to their school athletics carnival, or they've just got a big week on and they've got lots of kids in their family, people can do a lot of steps. And although it's not that high of a load walking, it's still a load that's worth querying, where we might need to take the return to running from 4 weeks to 6 weeks because you do so much loading outside of your actual meaningful activity, which there can be some really tricky stuff in there that you wouldn't even think of. Like in the gym, like if people are squatting heavy, that's still a load on the tibia. So you need to look at those things.
Mate, awesome. Anything else you want to go with, Connor?
No, I think that's been really good in terms. So we started with like risk factors, and then we talked about like why it happens, things to keep an eye out for, a few tips on how to progress treatment and things like that after you've diagnosed it. Only thing maybe would be like, yeah, in terms of, you mentioned CT, MRI, like in terms of diagnosis and progression, is there anything else we need to be doing to like nail down our diagnosis? And then once we've kind of got our diagnosis, are you doing things like re-imaging or anything along those lines?
Yeah, the re-imaging one is tricky. And I've had this conversation with many sports doctors and orthopedic surgeons around like we don't really know what you're looking for on imaging. So obviously you want to see some uniting and some bone changes, but it's probably not going to give you that much of a different look because it takes so long to change. And getting another MRI is probably not going to look too different as well. It's still going to have some edema. They're still going to have some changes. So your symptoms are still best. But my advice to people is if you're suspicious of a bone stress injury, you need to be getting an MRI. And I'll clarify this and I'll ask the opinion of you guys what you think of this next statement. But getting an MRI is great because it gives you a good classification of the edema, it gives you a good idea of what's going on. I think that with an X-ray, and I know Bo, stress fracture physio, I've spoken to him about this quite a lot, for the low risk areas, what do you guys think of this? If you suspect someone has a stress fracture and the symptoms match and it's been a long enough period of time, do you think that if you just send them for an X-ray, which is obviously a lot easier to get, and it comes back that it's clear of a fracture, you can probably say, okay, then, well, it's obviously not severe enough to a fracture. It's probably a high-grade stress response, and leave it at that. Follow the protocol of just following a normal higher grade stress response, offloading and boot, depending on, this is for a low-risk area. And then after you followed that, just return to normal? Or do you think that you do need to get the MRI to be able to get a better understanding of what's happening? Because the one thing you want to make sure is they just don't have a fracture, because then it might change a little bit with how aggressive the offloading is compared to if it's a stress response, it's going to be generally the same. What do you guys think of that? Like because of the MRI place is closed, I've got a good relationship with the radiographer and we work with the sports doctors. So typically that's what I will do, but I don't mind that idea. And I think it's definitely got some good ideas behind it, and the barrier to get it low, it doesn't cost as much.
So with the ones I see more often were like, lumbar ones with like say cricket and rugby league and gymnastics and some AFL players stuff before, and that is the direction I've gone with that stuff.
Like X-ray first.
Yeah. Yep, exactly. And gone, cool. Like if it's not picked up as kind of a, Scotty dog, well then I'm like, cool, well, we're going to be treating it like everything. It tastes like, it smells like a bone stress reaction, everything. I just wanted to rule out the fact that we don't have to do anything serious here, and that it's just unloading, and that's the direction I go. And it's more just because MRIing in like lower backs and etc. like I don't want to have to open up other conversations that might come up from that as well. You know what I mean? So Yeah, so that's more my experience. I actually haven't seen a heap of lower limb stress fractures just because of the populations that I've worked with mostly.
So on this, I saw a paper yesterday and it was talking, I think it was a series of case studies and it's in the UK and it was in runners. I think it was 3 different runners and they ended up with second metatarsal stress fractures. When the person presented with the main, like the injury on day 1, and they took an X-ray, there was like nothing that showed up on the X-ray. But they took kind of serial X-rays and it showed that at week 2 and then at week 6, like you could more clearly see the fracture at week 2, and then at week 6 you could see the resolution of the fracture.
Yep.
But literally day 1, week 6, there was nothing. So it would have been missed if they didn't take CT. And then it was clear at week 2 that there was a stress fracture. So maybe like X-rays aren't always the best to kind of rule it in.
And that was for a fracture, wasn't it?
Yeah.
So and that's like that's what I mean when the consequences are so high. If there's the potential chance, it's like, oh, I don't want to miss this, and I know with an MRI my sensitivity is going to be a lot higher, and I think it's about 270 to get it down here and get it within a couple of days. I guess I feel really confident explaining to people why they need to get it. Like, hey, this is how much it's going to cost, but this is why we need to do it. And it is probably the better test. Are you happy with that? And yeah, maybe, I mean, yeah, it's hard because then even really with the clinical stuff, like I think this with the metatarsals, I mean, if you feel someone's foot, it's you guys have it tougher above the knee. You can't just palpate someone's femur, and like I can really palpate someone's shaft of the metatarsal. It is so easy to do. Like there's nothing there. Like I can feel it. Navicular is the same. The tibia is the same. They're really exposed for me. So like if they've got pain on palpation on their bone, I'm pretty suspicious anyway. Obviously with their training history, so I could probably just. Yeah, I could really treat them without the imaging, but I've got enough evidence now to see, and I've seen people that have either been sent by the doc or from the orthopedic where the symptoms that presented, I would have thought that it was a low-grade stress response and it actually has been a fracture, and they've already had the imaging. So I think I'm too worried to try and just do it that other way.
I had one.
That's good, and I would agree. Like especially for me on that, like the only reason in the back that I go that way is because it's kind of the back and the things we know. But
are just high.
Yeah. Whereas like anything like, there's not this socio cultural kind of big issues with getting like a MRI of your, lower leg and finding that you have some sort of strange kind of tissue abnormality in your like Achilles versus, you know what I mean? Like,
but as soon as you see a disc bulge, oof, game over.
There's no disc in the below the knee. That's where it's all at. That's where the smart people are. Below the knee.
Like my constraints working publicly at the minute is that I can't get MRIs. Like if I want to send someone through like ortho or whatever else, like they're waiting 16 weeks to get an MRI. So
which I have a guy recovered anyway, whatever it is, probably.
So I have a guy, I literally put him in the boot Tuesday because I was like, even if you don't have the stress fracture, let's treat it as if you've got one, because it's probably in the scheme, like the grand scheme of you getting back to playing football, it's only going to be probably another month of you getting back to football. Whereas if we kind of ignore it earlier on and it does progress, or it does so essentially I assumed that it was broken without kind of telling him that it was. And I've kind of treated it that way because I just don't have access to like MRI or anything, like even an X-ray. So it was like, I just went, if in doubt, like, let's make sure it doesn't break.
That was the tibia, wasn't it?
Yeah.
You said? Yeah. I mean, like the clinical tests are pretty good. If they've got focal pain and they've got pain with hopping.
One spot.
Yeah, you can be pretty likely. But even in saying that, I have been time and time again, I have thought for sure, because you eventually, when I'm seeing them enough in my head, I'm like, I'm just going to really try and make some clinical decisions. Some clinical justification, not clinical decisions, clinical justification, and just see if this is right or wrong. So even like if someone had positive to those 2 tests, I'm going to be referring them for an MRI because I'm suspicious of a stress fracture, and that's what the evidence would support. But what I have been doing as well is just doing some other tests to see if I can potentially stress it more to give me more indication. So then when I send them for a scan, I'm like, oh, okay, maybe if I can add these battery of tests in to kind of confirm or deny the diagnosis. And time again, I have been caught out where it is just a stress reaction and it hasn't been a fracture. So it is really difficult. And obviously that would have changed my management. So that's why I think they can be important. But as you said, the access, the cost, these are all real barriers that people face all the time, clinicians included.
Yeah, great. Have you got anything else, Steve?
Biggest takeaway for me, I think a cool thing for me that kind of just puts things in the SRA cycle and the different types of the bone. So the more like spongy bone versus the more so just going like, you know, our lower limb. Yeah, that was great. And like thinking that, you know, our tibias or anything, like, because it's that more spongy, like it just so many more reps before it comes on. Whereas like it kind of now, you know, with our cricketers and whatnot, they're going, the risk factors can be like 80 odd deliveries. So, you know, like you're looking at like 10, 12 overs kind of thing. So it's a lot less load that a bone can take when it's not like exactly designed to be kind of, you know, it's not used to getting around and jumping on it and the different type of bone, just that it's a complete different magnitude of volume of load that it can take and intensity of load that it's taking before you're seeing these kind of stress reactions. And that's kind of why the protocols would kind of be so different as well. That
should be different.
Yeah.
And they heal quicker. Like, I don't know, we said like diaphysis fractures will heal quicker than like an irregular one, like the navicular. So your return and your rehab can change a little bit as well. I did want to say one last thing. I know I've said that probably 40 minutes ago. One different thing with below the knee is, I think, as we spoke about, you know, high cortical bone and just biomechanics mattering, you know, maybe a little bit more. That means that offloading can really play a really big role. So we can manipulate plantar flexor forces pretty well with a shoe that's got a high pitch and a pretty good rocker. And you can even then just put some heel lifts in there as well. And that works the same with MTSS. When it comes to the navicular ones, I think that you should consider referring or working with a podiatrist to give them some form of arch support. And it's only for the recovery phase and maybe 12 months after. Whereas if it's different through the arch, theoretically, it should be less tensile force across the top of that bone. And maybe for a medial or lateral one, you could wedge them and take some pressure off. So just some considerations. If it's been a recurrent one and they're really struggling and they're looking at everything else, it's like, well, shoes play a huge, big role. Shoes with carbon plates and stiff rockers reduce the bending moments like up to 17% in the metatarsal. So that's really cool. Like, these are easy things to implement to just help someone return a little bit quicker. And also somewhat of an insurance. Like, if I'm getting someone back running from a metatarsal bone stress injury, I'm like, hey, can you just wear your big, stiffer shoes just for the first 3 weeks to protect a little bit more, so they don't go from boot or then right to like nothing. They go from like boot to stiffer shoe, then to nothing. So there's just a little bit of kind of regression of protecting factors around there.
In my head, that works so well on the like long-term athlete development kind of framework thing. Because I explain like to people, so say if they've had a ACL injury or something, and I want to check in with you. I've discharged them, but I'm going to check in with you in 12 weeks. And in my head, why it hasn't been proven or anything, but in my head, why the first kind of, you know, year to 2 years post is still like a really high risk for that, is because both limbs are doing the same kind of activity there, right? But one limb is like relatively, as far as its training age, is a complete different train. Like the other limb has done so much more like loading and train. Yeah. So it's just, they're two complete different athletes trying to do the exact same thing. So, you know, I want to check in with you and make sure that after you've been doing heaps of loading with this, that like your testing, everything is still going right and you're having no issues, because I wouldn't send two separate athletes to do the exact same thing of different training ages, right? The youth athlete, I'd put him into first grade for a little bit, and then I'd take him back out for a week, and then I'd put him back in for another couple of weeks, and just I'd edge that out over longer. Whereas the veteran who's been playing forever, he can run through a whole season and is used to kind of getting getting hit and bashed around and battered around and doesn't need checkups. So that's kind of what that works in really well for me, because, you know, you're going from the boot, the training age is way lower there. Well, then they're going out running, right? One leg is a high training age. It's a veteran. It's used to getting bashed around, hitting. This other guy, because he's got to go for the same distance, let's give him a little bit of a support. Let's give him some extra kind of breaks as he needs it.
I like that. I like the training age one. Good.
Great.
All right.
Any other questions or points to make, Steve or Blake?
No, that's all from me. Thankfully, you have to end this call before I think of something else.
All good.
Brilliant. So thanks a heap for coming on, mate. That was super valuable.
Awesome, guys. Love the chat.
Yeah, hopefully a listener can take away some like pretty useful points. Like, it was pretty pragmatic, I think, in terms of examples of things you can do, things you should be looking out for. So yeah, really appreciate it. Where can our listeners find more of you?
Yeah, so just socials, blakewithers.sportspodiatrist, and our podcast is the Sports Medicine Project. And like, if you have any questions at all, like if you really agree with what I'm saying, please let me know. If you disagree, message Steve and Connor. They'll be able to help out. Agreeing me, disagreeing with them. They'll be able to help it with everything.
Perfect.
We love a good disagreement here. So
Awesome, guys.
So
thank you very much.
That was another RP podcast. Hopefully not an RP 10 to grind through. We might have to break this into 2 pieces, but thanks for listening, and we'll see you next time.
Gotcha.
See you later, guys.